touching back on what you said regarding quality of life improvement, can we talk a little bit more directly about what you see firsthand in your perspective as to what these patients, severe eosinophilic asthma in adults, what are they usually suffering from that is bolstered by biologics?
Yeah, so patients with asthma can be divided into patients who have more severe disease and less severe disease. And what we've noted is that a large proportion of the patients who have severe disease have eosinophilic asthma. They tend to have higher levels of blood or sputum eosinophils. And I think in that context, these patients tend to have more exacerbations. They tend to have lower lung function. They tend to have worsening asthma quality of life. And oftentimes they require oral corticosteroids. And so one of the things that we tried to seek was, can we reduce exacerbations? Can we reduce oral corticosteroid dose in these patients for patients who need it chronically? And can we improve asthma-related quality of life? And we demonstrated that there was improvement in each of those domains. So for instance, in terms of lung function, the mean FEV1 or forced expiratory volume in lung function prior to starting rislizumab was about 65%. And lung function improved out to 73%, which is a clinically meaningful improvement in those patients. That was clinically, improving lung function often translates to improvement in other metrics. And we demonstrated that as well. 70% of patients had an improvement in their asthma control test score of more than 3 points. That's, again, another clinically meaningful improvement in terms of asthma control for our patients. So those are some key metrics. We also were able to reduce the proportion of patients who had very poorly controlled disease to having well-controlled disease. And we reduced that from 67% who had poorly controlled disease down to 18%. So significant benefit in terms of improving overall asthma control for our patients.
That's excellent. And, those are the patients who need it most, it seems. So that's great to hear and very promising. Dr. Wechsler, where would this go now in terms of follow-up?
Yeah, so I think that there needs to be, in general, more real-world data generated. When you take patients out of the clinical trial, I think there need to be longer studies that evaluate how patients do in the long term. Do patients need these drugs for life? Can they come off of these therapies? At what point? And so I think those are some of the important questions. And then I think we also want to get a better sense of who the responders are and what differentiates the responders from the non-responders. Can we identify biomarkers other than eosinophils that can be predictive for our patients to improve outcomes for our patients?
It's great. It's great. And we'd be looking forward to seeing exactly how that would play out in terms of further assessment and obviously more clinical data and just better implications for the patients. And regarding the entirety of the biologic class, obviously we're talking about different pathway targeting therapies and obviously different roles and values for each one. But speaking broadly, there does seem to be some trends in the way they're going in the pursuits that a lot of clinicians are having in terms of their availability for allergic and asthmatic care for differing conditions. Can you give us, I guess, a very quick broadcast of exactly how you see the field right now and maybe what discussion was centered around if we're at ATS?
Yeah, so these are very exciting times for the management of asthma. We've gone from an era where we were just giving inhaled corticosteroids and bronchodilators to a more targeted approach. That's, when patients weren't responding to the standard inhalers, we were just giving them prednisone and oral corticosteroids. And those were with a lot of side effects and poor patient satisfaction and, frankly, not a lot of efficacy in a lot of cases. So now we've moved to an era where we're targeting patients based on their underlying biology, whether it's the eosinophil pathway, the IL-5 pathway, whether it's interleukin-4 and 13 and targeting those specific pathways, or targeting IgE and that pathway. And so now we have at our hands many different options, the right drug at the time for the right patient. And it's recognizing that asthma is a heterogeneous disease, and we need to target on the underlying biology, not just give a whole scattered approach for in terms of just giving broad corticosteroids. So this is very exciting, and I'm excited because there's other new therapies that are in development. Anti-TSLP, anti-IL-33, CRTH2 antagonists, a whole variety of different therapies that are targeted to specific mechanisms are emerging. And so I think this is a very exciting time. And I'm looking forward to the next few years to really have a better handle and give patients the right drugs for them.